Hi everyone, welcome to this lecture. We're going to go over the pharmacotherapies for smoking cessation, focusing on nicotine replacement therapy and varenicline. So nicotine replacement therapy was the first therapy that was approved for smoking cessation. Now, over time, studies have shown that more than 2/3 of cigarette smokers are interested in quitting. And nicotine replacement therapy can assist them in successfully quitting smoking. So the NRT formulations, nicotine replacement formulations, include a patch, gum, and a lozenge, as well as an oral inhaler and a nasal spray. Now, all of these drugs are available over the counter. And nicotine replacement therapy is actually just nicotine. It will replace the nicotine from tobacco. So nicotine itself is not a carcinogen. This nicotine will help reduce the withdrawal symptoms that people may experience when they're quitting smoking. And the 6-month quit rates with nicotine replacement therapy are significantly higher than placebo. Potential side effects include an increase in blood pressure and heart rate, as well as some nausea. So you may ask, well, nicotine itself is addictive. How do we know that nicotine replacement therapy is not addictive, and how can it be sold over the counter without any problems? The answer is in the pharmacokinetics of nicotine replacement therapy compared with cigarettes. So cigarette smoking causes a rapid absorption of nicotine into the bloodstream and rapid entry into the brain. This is associated with rapid reinforcement and the rush from cigarette smoking. Cigarette smoking is also a very interesting mechanism of delivering the drug because it allows for precise dosing by the user, and so the person can control the size and the frequency of puffs they take on their cigarette, or nowadays also on vapes. Nicotine replacement therapy does not replicate the rapid increase in nicotine blood levels, and also dosing is more tricky, which I'll talk about in a later slide. So here are two graphs illustrating the nicotine concentrations in the bloodstream from the different formulations of nicotine replacement therapy and from cigarettes. So on the left side here, you can see that cigarettes produces a very rapid increase in nicotine concentration levels in the blood after start of smoking. So it reaches peak in less than 5 minutes, and then it has this long taper. And as you can see, all of the formulations of nicotine replacement therapy, the gum at these two different concentrations, inhaler, nasal spray, and patch, do not replicate this quick increase. And in fact, the patch is the slowest formulation compared to the other NRT formulations. You'll also notice that smokeless tobacco, which is another form of tobacco that is popular in other parts of the world, also does not replicate this rapid increase seen with cigarettes. On the right-hand side, you can see the nicotine concentrations over time, and here on the top in the black circles are cigarettes, and already at 9 o'clock this person has likely started smoking. So the first cigarette of the day is often reported as the most rewarding compared to the other cigarettes of the day. And you can see here again, the patch causes a fairly slow increase in nicotine concentration in the bloodstream, whereas the gum formulation can cause these more rapid rises, but these formulations don't recapitulate the increase in nicotine concentration that's seen with cigarettes. So with nicotine replacement therapy pharmacokinetics, again, the patches are the slowest onset formulation, and they're very long acting, and they provide relief from withdrawal symptoms for about 24 hours or how long the patch is on, but it requires more than an hour to reach peak plasma nicotine concentrations. The other formulations, such as the nasal spray, the inhaler, and the gum and lozenge, have much faster increases in nicotine concentrations in the bloodstream. And so using a patch as baseline along with a shorter acting nicotine replacement therapy is much more effective in helping the person quit smoking than using just one product. And that's to allow the patch to build up a particular level of nicotine in the blood that will help alleviate withdrawal symptoms, and then the spray, gum or lozenge or inhaler can be used when the person is experiencing cravings. So this alludes to some of the dosing issues with NRT. The dose required by each person varies, just as the amount that the person smokes varies from person to person. So someone can be a half pack a day smoker versus a 2-pack a day smoker, and these people will likely require different levels of nicotine replacement to actually successfully alleviate with the withdrawal symptoms. And so often individuals may use too little nicotine replacement therapy to achieve withdrawal relief and subsequently have a higher risk for relapse. The second drug for smoking cessation is varenicline, and this drug needs to be prescribed. This drug is actually the most effective smoking cessation drug currently on the market. The way that it works is it's a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptors, and this drug was actually designed to be a partial agonist. The alpha-4 beta-2 nicotinic receptors are one of the subtypes that is the most critical in nicotine addiction mechanisms. And the partial activation of these receptors by varenicline will provide partial stimulation of the receptor and then help to reduce the withdrawal symptoms that somebody may experience throughout the day. On top of that, the partial agonism allows the varenicline to compete with nicotine for the activation sites on the alpha-4 beta-2 nicotinic receptor, which will help reduce activation from smoking and dampen the effect of smoking if someone does happen to smoke on top of this drug or to have a small relapse. It will still help reduce some of the activation from nicotine itself and help the person maintain long-term success.